So I'm doing new patient exams today, and my first patient for the day is Grace. And Grace has come in on referral from her dentist because of crowding, right? Now if you look at Grace's teeth, bite together Grace, you can see she's got no room for her canines, right? But if you look closer, open up really big, you see how narrow her palate is. When I see a kid who has a narrow palate, we always suspect either a habit, like thumb sucking, or many times airway obstruction. Now if you look at Grace's tonsils, can you say ah, big ah, okay? You can see they're blocking her airway, right? So look at those tonsils, they're a grade 3 tonsil. The other thing is we look at the method of breathing, and she tends to be obviously a mouth breather. So bite together again. So the classic is we have a narrow palate with a cross bite. We have an associated anterior tongue thrust, open again, because the tongue can't really sit there. So if you look at the side of the tongue, just poke your tongue forward a bit, you can see the scalloping of the teeth on there. So scalloping on the side of the tongue, narrow palate, large tonsils, all that's a clue as to what we would need to do. Bite together again. In the old way of doing orthodontics, we would just extract some teeth. Open again. Normally these ones, these premolar teeth. And that would get the eye teeth down very quickly, but the problem is the palate still remains narrow, so the tongue still hasn't got room. Lots of research now are linking expansion of the palate to improve the nasal breathing. So for this young lady, we'd work with an ear, nose and throat doctor regarding the large tonsils, and we would then expand the upper jaw to make room for the teeth. Once the expander comes out, we'd then train Grace how to change her tongue posture from forward to upward. Now, let's have a look at something else here. I'll take my gloves off. This is Grace's lateral ceph x-ray, and you can see the large adenoids, right? Another name for adenoids is the nasopharyngeal tonsil. So air going through the nose is being blocked in a number of occasions here. You can see the nasal polyp quite clearly there. You can see the large adenoids, and in the mouth I just showed you the large tonsils. So all of that paints a picture to her breathing habit. Now look at the angle of the teeth. You can see the tongue get in there. That is what's called a tongue thrust, and that's what's causing those teeth to procline like that. We have a brochure which we give to parents. I'm happy to send anyone who wants a copy of this. This brochure explains to parents the link between the narrow palate and the mouth breathing, and explains all the common sites of obstruction which I've just gone through, and how we want to get the jaw from that size to that size. We also have included a range of references that talk about the narrow palate and the compromised nasal airways. It's called a hyrax. We put bands on the back teeth, you turn a key, and it widens the palate. But we do it slowly, and by doing it slowly, I find I get better remodeling of the palatal vault. So the palatal vault is the floor. Off the nose, quick anatomy lesson, here's the arch form we need. Why is it like that? Because the tongue sits up there. If the tongue's not there, for whatever reason, then the buccinator muscles take over and squeeze everything together. So look at the anatomy, the nasal floor, the palatal vault, two are very much related. So if I can widen here and my ear, nose and throat doctor can clear the plumbing there, we're going to get a much nicer result. But the earlier you do it, the more that face is going to grow forward. The longer you leave it, the more you're going to end up with a mid-face deficiency.